Okay.
Okay, so next question. Can you repeat what you said about high blood pressure and relation to macrosomia?
Oh, yeah, like hypertension cuts off the blood supply to the placenta, and you get uh, growth retardation. So, the truth is the blood sugars could be 1,000,000, but if your blood pressure is elevated, the baby could be intrauterine growth retarded. I'm more worried about the blood pressure if the babies are too small than it was my blood sugar. I have never in my career ever seen a baby too small. The truth is, if you just look at percentile birth weight, there is a U-shaped curve. So if the blood sugars are absolutely normal, you get a perfectly normal birth weight child. If the blood sugars are too high, you get a macrosomic kid. But if the blood sugars really average less than 70, you can get a baby that's in the 10th percentile birth weight. Now, it doesn't mean it's a bad baby, because kids, end up undoing their being intrauterine growth retarded. The other thing that sometimes happens is our obstetricians get a little nervous because our women are on insulin and they want to deliver them early. I don't want my babies to be premature, but I can't argue with the obstetrician. So if the obstetrician delivers the baby because the obstetrician thinks the baby's going to get too big, I mean, the baby's not going to get too big because the blood sugars are normal, but many times we've had small infants just because they've been born prematurely because the obstetrician got nervous.
Okay. How many grams of carbohydrate do you recommend daily? And do you minimize the carbs at the breakfast because of the hormonal stuff?
Absolutely. Absolutely. We, at breakfast, are only allowed to eat protein and fat, period. And I'm almost rigid about it. I tell them if they want to skip breakfast, because if they have morning sickness, it's fine if they skip breakfast. Because the truth is I need to get them out of the dawn phenomenon, away from the time where they're so carbohydrate resistant, intolerant, that I need to get them away from that and have them eat a little later. And so once they get past that time zone, which is really usually after 10 a.m. in California, they can eat a little bit more carbohydrate. But for breakfast, it's almost zero. I don't allow them anything white. So when they talk about a sandwich, I go nuts, because a sandwich means 2 slices of bread. So I say, so tell me what you put in between it, And we start to focus on what you can't eat. I ask them to take away everything white. So it's bread, rice, pasta, tortillas, and cereal. It's really, potatoes are in there too, but most of my women are mostly tortillas and rice.
And is there a minimum that you'll do with the carbs?
No, and in fact, there's a statement that says you need 150 grams of carbohydrate a day for pregnancy. It comes from nowhere. There's no science behind that statement, and nor does it calibrate it based on body weight. It's just an absolute statement in the nutrition books. It comes from nowhere. There's no reference. It's just a statement. And that's why I keep arguing. If you have no proof that this diet is healthy in diabetes and pregnancy, it doesn't mean that I have to force feed 150 grams of carbohydrate to anybody. So, it's Lois's opinion. I can say whatever I want. I've got a license to practice medicine.
Do you see maternal weight gain issues with the carbohydrate restrictions?
No, and in fact, the truth is my women tend to have already gained a ton of weight before they're referred to me. So they've gained the 22.5 pounds the American Institute of Medicine claims you're supposed to gain, plus twice that, before they even meet me. So the diets that I put them on are usually a weight maintenance, or some of them, if you realize they're going from 5,000 calories to 2,000 calories, obviously they're going to lose a little weight. What I make sure is they don't have ketones in their urine before they go to their doctor's office, because obstetricians somehow think ketones are associated with dumb babies, which isn't true if you also want to do a literature search on ketonuria and intelligence quotient. But I ask them, just take care of me. So before you go to your obstetrician, make sure you eat before you go, because then you won't have ketonuria and your obstetrician won't tell you you have to eat more. So you kind of hear what are the buzzwords in the obstetrical service, but they also realize in obese women, it's really wrong to make them gain weight. There's plenty of stored food for the baby for them not to gain weight. So the truth is, everybody should be asking their own obstetricians, what do you do if a woman's already gained weight when you meet her? You don't have to force her to continue to gain weight. In fact, it might even be healthy if she lost a little weight.
Okay. Do you start insulin when the fasting blood glucose are 90 to 95, but only 10% of the postprandials are elevated?
I do, because that would mean the A1C was above 5.3. I mean, because that means the average blood sugar is going to be higher than 5.3, and the risk of macrosomia is going to go up. And I tell them they may want a trial of diet, because it could be their blood sugars are like that because they've been eating a little bit, partying a little bit too much before they met me. So some of them plead with me for 1 week of showing me they can do it with diet alone. I know they always surprise me, but it is true. They've lost 5 pounds, their blood sugars are normalized, and they're doing super. There are other women that I say, you know, we're just wasting another week of the baby's life. Please let me start you on insulin now. And the truth is, if you do well, the baby will be healthy. It depends. I sort of watch the woman's body language as I'm suggesting what we should do. There are a lot of women who plead with me with their eyes to give them 1 week to try because they don't want to tell me the truth of what they've been eating before they met me.
Can you repeat the name of the Detamir insulin pregnancy study?
Yeah, Elizabeth Mathieson is the first author on the metabolic paper, and Moshe Hood is the first author on the obstetrics outcome paper, and Detamir is Levemir. The brand name is Levemir, but the title of the paper, if you put Detamir, D-E-T-E-M-I-R, into PubMed and pregnancy, you'll come up with all of the research on Detamir.
Thank you. What target A1C should we be looking for women with pre-existing diabetes before they become pregnant?
Yeah, well, the increased risk of malformations is above 5.3%. So we really push women who are planning pregnancy to really not, I mean, especially if they're planning pregnancy and there's a choice when to get pregnant, it's nice for them to get permission to get pregnant when their A1C is less than 5.3%.
Okay, we're back to the acanthosis. Women
Yes.
with lighter skin, do you see the same?
I do. I do. You have to look closer, though. You can see it. You can feel it. You have to look closer. You're absolutely correct. But it is darker than the rest of their skin. You can actually see it.
Okay.
But you have to ask them to lift up their hair and look very carefully, and then you can say, oh, yes, you do have these little lines there. You have to tell the patient, though, because if you're in a teaching situation in clinic, that you're really just showing where the extra insulin is hurting her skin, and that's all you're showing her. And she may not have noticed if it's only on the back of her neck.
Next question, have you changed the postprandial numbers from 130 to 120?
I've never been 130.
Okay.
Yeah. I think my biggest fight in life was either making the diagnosis of gestational diabetes or convincing docs to do the 1 hour instead of the 2 hour. I'm not sure I've won either fight in my career. But, the truth is that's why one of your questions was, are you doing the 1-step or the 2-step, and are your doctors giving oral agents? I mean, the truth is I treat the blood sugar and normalize it by hook or by crook. And so, the truth is it's always been 120 because that slide I showed you where there's an elbow exactly at 120, actually it occurs at a blood sugar closer to 115 if you look carefully at that elbow. But if they stay less than 120 1 hour after eating, then I feel reassured the risk of macrosomia is not increasing.
Thank you. Is Lantus insulin safe during pregnancy?
Lantus is glargine.
Okay.
And a couple of my slides were on glargine. I tend to use, of course, generics rather than brand names, mostly because our medical school won't let me use brand names. But Lantus is glargine. And glargine has a very high IGF-1 component. And I'm a little concerned, besides it being too flat, so, if you give a lot of insulin in the evening to normalize the fasting, the women tend to get hypo midday because of the collision of their other insulins. But the biggest concern I have actually is the IGF-1 quality, because if my women have even a little bit of retinopathy and they're taking a drug with more growth-promoting factor, I'm concerned that it's increasing their retinopathy risk. So, I mean, the truth is, glargine doesn't fix all the blood sugars. It isn't a 24-hour insulin. It really is only a 16 to 18-hour insulin. And if you're going to take it twice a day, you might as well take an insulin that is a category B and not an insulin that is, glargine is not, it's a category C.